Ground rounds pharmacology treatment for major depressive disorder in an 18-year-old adult. Patient overview. Sarah Thompson, age 18-year-old, diagnosis major depressive disorder MDD. Sarah presents the 6 months history of depressive symptoms, including persistent depressed mood, anhedonia, insomnia, fatigue, significant weight loss, feelings of worthlessness, and recurrent thoughts of death. Her symptoms met diagnosis criteria for the major depressive episode and indicate clinically significant impairment requiring evidence-based intervention. Before initiating medication, a comprehensive psychiatric assessment should include evaluation of suicide risk, severity of depression, psychosocial stressors, substance use, bipolar disorder screening, medical conditions, and patient preferences. First-line pharmacological treatment selection. Selected medications: sertraline, Zoloft, medication class selective serotonin reuptake inhibitor (SSRI). Initial dose: 25 to 50 mg orally once daily. May increase gradually based on response and tolerability. Typically, therapeutic range 50 to 200 mg per day. Selected because SSRI are considered first-line pharmacological treatment for MDD in adolescents and young adults. Sertraline has a strong evidence supporting efficacy, safety, and tolerability. It has a favorable interactional profile compared with many alternative antidepressants. It is appropriate for an 18-year-old experiencing moderate to severe depressive symptoms. Current guidelines recommended SSRIs are first-line pharmacotherapy for depression due to their effectiveness, tolerability, and lower risk compared to other older antidepressant classes. Pharmacodynamics mechanism of action. Sertraline works by selectively inhibiting serotonin reuptake through blockade of the serotonin transporter SERT in the presynaptic neuron. This mechanism results in increased serotonin availability within the synaptic cleft, enhanced serotogenic neurotransmission, improved regulation, emotional processing, sleep, and anxiety symptoms. Although serotonin changes occur shortly after medication initiation, clinical improvement typically requires several weeks due to downstream neuroadaptive changes involving receptor sensitivity and neuroactivity. Pharmacokinetics and metabolism. Sertraline is apparently metabolized through hepatic pathways including CYP2B6, CYP2C19, and CYP344. Important consideration for Sarah. She denies substance use and has no known medical condition, reducing concerns regarding drug interactions. Sertraline has a relatively favorable safety profile in young adults. It has a half-life of approximately 26 hours, allowing once daily dosing. Monitoring is still necessary because genetic differences in CYP metabolism may influence medication response and adverse effects. Expected benefit and treatment goals. The goal of sertraline treatment include reduction of depressive symptoms, improvement in sleep and energy, restoration of academic and social functioning, reduction of suicidal thoughts, prevention of depressive relapse. Patients should be educated. Antidepressant typically requires 4 to 6 weeks for noticeable improvement, with continued improvement occurring over subsequent months. Medication effectiveness should be evaluated using clinical assessment tools such as patient health questionnaires, PHQ-9, clinical symptoms evaluation, functional improvement assessment. Safety consideration and adverse effects. Common adverse effects include nausea, headache, insomnia or sedation, sexual dysfunction, gastrointestinal symptoms, increased anxiety during initial treatment. Important safety concern: increased suicidal thoughts in young adults. The FDA requires monitoring of antidepressants treated patients younger than 25 years because some individuals may experience increased suicidal ideation early in treatment. Sarah should follow up within 1 to 2 weeks after initiation. Suicide risk assessment at every visit. Education for family and support system regarding warning signs. Alternative medication options. Alternative 1. Fluoxetine Prozac. Fluoxetine is another SSRI with strong evidence for treating depression in younger population. Advantages: long history of use, FDA approved for adolescent depression, long half-life, reduces withdrawal symptoms. Potential disadvantages: longer half-life may make dose adjustments slower. Alternative 2. Escitalopram is a SSRI option with strong tolerability. Advantages: minimal drug interaction, effective for moderate depression, generally well tolerated. Potential disadvantage: monitoring for QT prolongations may be needed in patients with cardiac risk factors. Pharmacological treatment recommendation. Medication should be combined with psychotherapy whenever possible. Recommended intervention. Cognitive behavioral therapy (CBT) helps identify and challenge negative thought patterns, improve coping skills, reduces depressive mood. Lifestyle intervention. Regular exercise, consistent sleep schedule, balanced nutrition, social support development, stress management strategies. Evidence demonstrates that combined psychotherapy and pharmacotherapy may provide superior outcomes to moderate to severe depression compared with either treatment alone. Patient education. Carers should be educated that antidepressants must be taken consistently for effectiveness. Medication should not be stopped suddenly without provider's guidance. Improvements may take several weeks. Side effects should be reported rather than discontinuing the medications independently. Family support persons should understand warning signs of worsening depression. Increased isolation, increased suicidal thoughts, sudden behavior changes. A safety plan should be developed because Sarah reports recurrent thoughts of death. Special population consideration. If Sarah was 8-year-old, treatment would differ because children require greater emphasis on psychotherapy as initial treatment, careful developmental assessment, family involvement. Fluoxetine has the strongest evidence and FDA approval for pediatric depression. Medication initiation requires close monitoring due to increased risk of suicidal thoughts in younger patients. If Sarah was 18-year-old with polypharmacy, treatment will require a different approach because older adults are increased risk related to drug interaction, falls, hyponatremia, cognitive effects, cardiac risk. A medication with fewer interactions such as sertraline and extrapam may still be considered, but treatment would begin at lower dose, slower titration. Start low and go low. Conclusion. Sertraline is an appropriate first-line medication choice for Sarah Thompson due to the evidence-based tolerability, suitability for young adults with MDD. Successful treatment requires medication management combined with psychotherapy, safety monitoring, patient education, and ongoing evaluation of symptoms response. The PMHMP must individualize antidepressant selections based on age, severity of illness, comorbidities, safety risk, and patient preferences. Citation. Reference: APA 7th edition, American Psychiatric Association 2023, National Institute of Health and Care Excellence 2022, Otter Gold Phoenix 2022, and Cupia Miguel Serhova et al. 2023.